Hey, and welcome to my video. My name is Sarah Seafelt, and I'm a senior nursing student at Georgia Highlands College. I want to go ahead and start this video by saying this is for informational and educational purposes only. This is not medical advice. Please consult a trusted health professional or your physician before making any medical decisions. I'm here today because we have a problem, and one that is, for the most part, being ignored and swept under the rug. And it has the potential to save a lot of lives and prevent a lot of women from having unnecessary complicated surgeries. So, the World Health Organization recommends that a state or a country or a physician has a C-section rate of 15 to 20%. And their studies have shown that anything higher than that doesn't show an improvement in outcomes. It's staggering, to say the least, that the United States C-section rate is 32%. With some states, like where I live, Georgia is 35.2% of all births are ending in a C-section. That's a major abdominal surgery, and it does come with its fair share of risks. I'm here to talk to you about a solution, and it's something called a TOLAC and a VBAC. And those acronyms stand for Trial of Labor After Cesarean and Vaginal Birth After Cesarean. Another major problem that we're having is that a lot of women don't even know that having a vaginal birth after a C-section is even possible. They've heard the adage, once a C-section, always a C-section. And that's simply not true. It's not best practice. I'm going to go into depth and kind of show you why. So studies show that only 10% of second-time moms that had a C-section the first time are even told that having a vaginal birth after cesarean is even an option. Even doctors that are willing to perform and provide care for VBAC patients are not offering them to their patients unless asked for. This is a problem because while VBACs do have their risks, all births do, and C-sections have their risks. And a lot of times I'm hearing from women that when they're told about a VBAC, they're told all of these scary numbers about uterine rupture and fetal death, but they're not getting consulted on the risks of repeated cesarean sections. So we need to explore that a little bit more and ask our doctors why that is and encourage them to look up more recent studies, look up more recent practice bulletins, and keep up to date with the best evidence-based practices. Something else I think that's really important to discuss in regards with this video is something called informed consent. And basically that means that in any medical decision that you make, you should be counseled on the reasons why it's a good idea, why it's a bad idea, but ultimately you need to be educated to make those decisions. Because at the end of the day, any medical decision is your decision. It is not your doctor's. It is your decision. Because in the United States, here we have medical autonomy, which means you have the right to make any decision regarding your own health care. So I have a quote here from the United Nations General Assembly, and the quote says, "Failure to provide informed consent during pregnancy and childbirth is a violation of a woman's fundamental human rights." Women are not being counseled, they're not being educated, and they're not being informed to make decisions. One of the ways that we can change this is by advocating for ourselves. As a patient, you need to speak up. If you want to try a TOLAC, you need to tell your doctor that that's what you want to do. Be firm about it. If they say that they don't provide that, first, I think you should ask why not. Ask them for studies and reasonings, and then you should move on. Find a doctor or a provider that wants to support you. They're out there. The more that patients leave practices when they're not getting the care that they need and evidence-based care, the more these doctors are going to actually start looking into evidence-based practice and providing that care. At the end of the day, human medicine is a business model, and if patients are leaving to go to doctors that provide informed consent and evidence-based care, sooner or later, all physicians will follow that model. So, the NCHS data brief from March 2020 states, women who deliver vaginally after a previous cesarean section are less likely to experience birth-related morbidity such as blood transfusion, ruptured uterus, unplanned hysterectomy, and admission to the intensive care unit than women who have repeat cesareans. That right there should make you question why this is not being offered. I think it's important to note that not every woman is a good candidate for a TOLAC and a VBAC. Some things that would prevent you from doing this or make you a poor candidate would be having an unusual C-section scar, which would be like an inverted T or a classical incision, which is where it's vertical up and down on your belly. The American College of Gynecology states that most people with one or two prior low transverse C-sections, which is where your scar is on the lower part of your abdomen going across, are good candidates to have a VBAC or to have a trial of labor after cesarean. Studies also show that women with a twin gestation after one prior low transverse cesarean are also good candidates, and studies have shown no increase in risk for women with twin gestations than singletons. So why should you consider a TOLAC and a VBAC if you've had a prior cesarean? First, you can have shorter recovery times than a cesarean, which is especially important when you already have a little one at home that you need to take care of. You have a lower risk of complications like blood transfusion, postpartum hemorrhage leading to a hysterectomy, lower rates of infection, and numerous others. Studies show that mothers that have a VBAC have better breastfeeding rates, and there's reduced long-term risks, such as you'll have a lower risk of developing placenta accreta or placenta previa, both of which become more and more common after each additional cesarean, and I'll touch on those a little bit more later, but both of those can cause life-threatening effects. All right, so let's get into the risks. Can you tell me what some of the risk factors are and why doctors may stay away from offering VBACs?
Or VBAC. There is a generally increased risk to both the person having the baby and the neonate with a TOLAC as compared to a scheduled cesarean delivery. We have to discuss this in a way that makes sense. What's the safest way to have a baby? A normal vaginal delivery. What's the second safest way? A scheduled repeat C-section. What's the third safest way? A C-section that happens in the process of labor. Obviously, going into this, you don't know if you'll fall into number 1 or number 3. These are not really easy to compare one-to-one. As compared to a scheduled repeat cesarean delivery, TOLAC is going to have an increased risk of infection, increased risk of blood transfusion, and an increased risk of something called uterine rupture, which we'll talk about in a moment. As far as risks to the baby, you do see a slightly increased risk of seizures, needing respiratory support, and even neonatal mortality or death with VBAC. However, really important in my opinion to discuss absolute versus relative risk. There is a slight increase in the relative risk, but the absolute risk of all of those things remains incredibly low. For most people, that slight increase in risk is outweighed significantly by the benefits of avoiding a major abdominal surgery. This is person dependent and definitely an individual decision to be made. Now,
the big one we always hear about is uterine rupture.
So what is this? Uterine rupture is when a scar on the uterus where a previous incision had been brought back together comes apart during the process of labor. This is a rare but potentially life-threatening complication that can happen in somebody who's had a prior C-section and is planning for a vaginal delivery. The risk of that is incredibly low. If you've had one prior cesarean delivery, the risk is about 0.5%, which is 1 in 200, and all of those will not be catastrophic. Some of them will, and some of them will just be minor. And the risk in a scheduled C-section, because it can happen prior to the time that the C-section gets done, so there's still a risk in any pregnancy when you have a prior uterine scar, is about 1 in 3,000. So that's a significant difference in risk, about 18 times higher in people who are planning a trial of labor after a cesarean. However, the absolute risk is still incredibly low. And of those people who have the uterine rupture, the risk of that being catastrophic, meaning someone dies, the fetus dies, somebody needs blood transfusions, hysterectomy, things like that, which are all possibilities, is still relatively low. So a risk, a real risk, one to be considered and taken seriously, but still relatively uncommon, even in people who choose to have a TOLAC.
And this is dangerous for the baby because this can cause the placenta to detach. It can cause bleeding for the mom, and the baby, once they're in the abdominal cavity, can cause damage to internal organs. This is exceptionally rare. I also want to make it clear that uterine rupture is not something that only happens with VBAC patients. A uterine rupture can happen to any patient anytime, and is even common with Pitocin, which is what they typically use to induce labor or to augment your labor and help it along. There's certain things that increase your risk when you're having a VBAC. That would be having an unusual scar, or if you don't know what kind of scar you have, It would be having a shorter interval between births. So somewhere between 18 to 24 months is the time that you want to shoot for between births if you want to attempt a VBAC. And certain medical conditions, having a prior uterine rupture would exclude you from trying to have a VBAC. Having certain uterine surgeries could also prevent you from having one. Success rates for VBACs are generally pretty high. The success rate is about 60 to 80%, with most studies on the higher end, which is a little bit astounding considering that our C-section rate is around 35%. There are certain things that can increase your chances of having a successful VBAC. These include having a prior vaginal birth, that could be before you had a C-section or after your C-section. Going into labor naturally rather than being induced gives you a better chance at having a successful VBAC. The reason for having your prior cesarean is also indicative. Patients who are labeled failure to progress or failure to descent typically have a lower success rate, but this is all individual, patient to patient, and having that prior reason as why you had a C-section is not a reason to disclude attempting a trial of labor after cesarean. Some women are going to be here because they had a cesarean because their first baby was breech, and maybe their second baby is now breech. There are providers that offer breech VBACs. So studies show that having an ECV, or external cephalic version, which is where they attempt to manipulate your baby and turn them while you're still pregnant, is safe and reasonable after a cesarean. So ask your provider if they'll provide this. If they won't, consider looking into a different provider. So why are providers so hesitant to offer VBACs? Or why are providers saying, yeah, I'll do a VBAC if your baby weighs less than 7 pounds, if you go into labor before 38 weeks, if you go into labor on a Tuesday under a full moon and you ate a strawberry milkshake that day. I think a lot of reasons come down to they're not keeping up to date with evidence-based practice. They are stuck in their ways and they have not decided to venture out. Some of them may have been around in the late 80s when VBACs were on the rise, but so were malpractice suits, and the two kind of got shoved in together. I think some providers are scared of VBACs for litigious reasons. Some doctors will also cite a fear of the risks associated with a VBAC, but all risk is relative, and the relative risk of a VBAC is very similar, if not better, than compared to a repeat cesarean. So why are we okay with the risks of repeatedly cutting women open, but we're not okay with the risks of allowing them to do what their body is meant to do naturally? And finally, the American College of Gynecology recommends that VBAC patients are more closely monitored.
In the process of labor, for somebody who chooses a trial of labor after cesarean or TOLAC, we're going to be watching the baby's heart rate closely. So we're going to want you to have continuous fetal monitoring. The reason for this is if a uterine rupture occurs, generally that's going to be identified or manifested, at least in some part, with a drop in the fetal heart rate. There are other things we watch for, but I think the most important thing here is that we highly recommend people have some kind of IV access so that if there is an emergency, we can take care of it, and continuous fetal monitoring so that if that uterine rupture does occur, we can notice that it's happening or potentially guess that it's happening as soon as possible and take care of it before it becomes a catastrophic problem.
And they also have a recommendation that any hospital that provides care for VBAC patients should have access for emergency surgery to do emergency deliveries. I think any facility that is delivering babies should be equipped to perform emergency deliveries. Do research into the facilities that you're giving birth at. Make sure that they have the ability to care for babies that are born preterm. Make sure they have the abilities to perform emergency surgery. Make sure that they have an anesthesiologist on staff 24/7, that if you need to be put under, you can be put under. I'm hoping that one day we'll see the change, that we'll have more and more providers offering and supporting VBACs than we do cesarean section. Something I touched on earlier was the risk of repeated cesarean sections. One of those risks is placenta previa. This is where the placenta attaches when you become pregnant too close to your cervix, and your cervix is at the very top of your vaginal canal, and that's where the baby exits the uterus and enters the vaginal canal to then exit. So what happens when the placenta attaches over the cervix, your baby can't go down because they're stuck on top of this placenta. So what happens if you start to dilate with the placenta here, and it starts to spread open, all of the blood vessels that are attached right here are going to get ripped free. And what that's going to cause is massive bleeding, and this can be a deadly complication. This is something that's typically caught very early on with ultrasounds, and if this is something that you are diagnosed with, you'll be scheduled for a cesarean probably a little bit early just to make sure that you don't go into labor, and they'll monitor you in case you have any episodes of bleeding. Your risk of developing a placenta previa increases with each subsequent cesarean section that you have. It does have scary consequences, but overall, it usually has a good outcome. The second major problem with repeat cesareans is something called placenta accreta. And this is something that occurs when your placenta attaches into your uterine wall. Typically, it just lays on top and the blood vessels grow in between. What happens when you develop placenta accreta is that your placenta has these little fingers that attach into the uterine wall, but they go too deep. And what happens is that when the placenta tries to detach, it can't. And when they remove it, it leaves holes in your uterine wall that then bleed. There's different levels to placenta accreta. The first one I spoke of, when it just kind of attaches in, is the mildest. There's also another level where it goes fully through the uterine muscle, which is more severe. And finally, it can actually go all the way through your uterine wall and into your surrounding organs. This is a really dangerous condition because even if they know that you have it, it doesn't change how they address it. They still have to go in and try to stop all of the bleeding as they're delivering your baby. And it has a really high hysterectomy rate, and it also holds a 7% maternal morbidity rate. So what are the numbers here? After your first C-section for your second birth, your risk of developing placenta accreta is 0.31%. That's a pretty relative risk compared to a uterine rupture is about 0.47%. With your third C-section, so this would be your third child, your risk then jumps to 0.57, which is now higher than a uterine rupture rate. Now let's say you want to have a big family. You go for that fourth baby. With your fourth cesarean section, your risk is now 2.13%. And your fifth jumps again to 2.33%. And then we see a massive jump. If you are having your sixth C-section, your risk of having placenta accreta is a staggering 6.74%. If you know that you only want 2 children and you want to have your tubes tied for your second baby, it might be a good idea for you to have a second cesarean because they can easily tie your tubes or sever them while you're getting your C-section. But if you know in your heart that you want a big family, you should heavily consider looking into having a VBAC because it allows you to safely have more children. So here's the point I want to drive home. Your risk of a uterine rupture with a VBAC is, we'll just say 0.5% to 0.9%. If you have a catastrophic uterine rupture, so that's what I was talking about earlier, the actual uterine rupture where your uterus rips wide open and your baby is free floating in your abdomen, your risk of perinatal mortality is 1.6. Now compare that to the placenta accreta mortality rate, which is 7%. So why is it that doctors say that the 0.5% risk of a uterine rupture is so dangerous and is reason not to have a VBAC? But they gladly allow women to have third and fourth C-sections where their risk of developing placenta accreta is just as high, if not higher, than a VBAC, and yet has a staggeringly higher mortality rate. Why is this disconnect happening? Why are we allowing women to have risky births one way, but not another? So one of the things I think it's important to consider with cesareans is that each C-section you have increases your risk for, funnily enough, uterine rupture, placenta accreta, placenta previa, infection, postpartum hemorrhage, and a full hysterectomy, and even maternal death. All of those risks go up every single time. So how can you advocate for yourself? First, make your wishes known early on in your appointments. Bring up that you want to have a trial of labor after cesarean in your very first appointment. Better yet, ask the receptionist when you call. Is this something that your providers offer? Do all of the providers offer this? Because I've seen a lot of women get into a situation where they find a great doctor that is super VBAC supportive, everything is wonderful, but then that doctor is not on call when they go into labor, and they're stuck with a doctor who does not support VBACs. Look for a practice where all of the doctors and providers offer VBACs. Ask your doctor what their VBAC success rate is. Ask them what their cesarean rate is. Find someone else. I think you should also consider looking at practices with certified nurse midwives or CNMs. The midwifery model of care is typically a little bit more patient-centered, and studies show that midwives typically have higher VBAC success rates. I think it's also really important to ask at that first visit, under what circumstances would you require a cesarean? Another really important question that's very telling is, will you induce me as a VBAC patient? I think a lot of people find that providers say that they're VBAC friendly, but they put a lot of stipulations on it that don't follow evidence-based guidelines. Women state that their doctor offers VBACs, but only if they have an epidural, if they show up to the hospital and they're at least 7 centimeters dilated, etc. Inducing with a trial of labor after cesarean is a safe and reasonable option. There are certain things that are too dangerous to do. There are a couple cervical ripening agents that are not considered safe. It's called Cervidil and Cytotec. These are both medications that are typically put up near your cervix, or one of them is often put like in your cheek. And these medications drastically increase your risk of uterine rupture. With already having a slightly higher risk of uterine rupture when you're having a VBAC, it's not safe or reasonable to add on inducing with a cervical ripener. That doesn't mean that you don't have options though. They're slightly dilated, so anything more than really a fingertip, there are methods that are called mechanical induction, and that's where they take either a Foley catheter, which is what they typically use as a urethral catheter to drain urine out of your bladder. But what they can do is they can put it into your cervix and then blow up the little balloon, and then that can be used to help dilate your cervix manually. There's also something called a Cook's catheter, which is very similar to the Foley, except it has two balloons, so it can put pressure on your cervix from both sides. They can also rupture your water and see if that will start labor. They can do cervical sweep. They put their gloved finger inside the lip of your cervix and they attempt to loosen the membranes that are around there, and sometimes that can jumpstart labor. And then there's also low and slow Pitocin, which is a medication we spoke of earlier. It is a labor augmentation medication. It helps stimulate uterine contractions, and when used at a very low dose, it can safely induce contractions that can even jumpstart your labor to where they can turn the Pitocin off later on. Important to advocate for yourself and make sure that it's being kept low and slow to avoid hyperstimulating your uterus. Red flags to watch for when you're interviewing or meeting with different providers is, I think the number one red flag for me is when they say, "Yeah, we'll do a VBAC. We'll decide for sure at a later date." That's a red flag. They're going to change their mind. They're going to tell you you're not capable. It's called the bait and switch. That say, "Oh yeah, I provide VBACs," and then they go on for 36 minutes about all of the risks and why they're so dangerous without explaining any of the benefits or discussing the risks of having a repeat cesarean. Again, run. And I think another really big one is providers that offer information that is inconsistent or outdated with current guidelines. Look for physicians that are up to date on the best evidence based practice. Look for physicians that quote ACOG for someone that seeks to educate you and make you empowered to make your own educated decisions. Again, this is just to educate you and inform you, search to find the best provider possible for you. So, how can you find these providers? First, use social media. Look into Facebook groups that support VBACs or just Facebook groups for moms in your area. Look up these groups, ask for recommendations, ask who's had a VBAC, find providers that care. There's also websites like the VBAC link. They also have a wonderful podcast. There's ICANN, which is the International Cesarean Awareness Network, and there's different chapters, and you can find a chapter near you that has resources and lists providers in your area that are known to support VBACs. There's also websites like evidencebasedbirth.com. While I think the option to have a VBAC is very important, I think the option to decide is the most important. If the risks outweigh the benefits for you, that is fine. But do your friends a favor. If they've had a C-section, ask them if they've heard about a VBAC. Ask them if they know the benefits. Ask them if they know the risks. Spread word. Let's get women talking about this. VBACs are safe and reasonable, and they're backed by evidence. And there are significant benefits for health and recovery. VBAC doesn't need to be a scary, dirty word whispered to your friends. Say it loud, say it proud. It's taboo. I see it all the time in women's Facebook groups where women say they want to have a VBAC, and suddenly they have 47 moms jumping on them telling them they're going to kill their babies because of uterine rupture. But these same women are perfectly fine with these women undergoing 4 C-sections with massive postpartum hemorrhage risks. It's taboo and it doesn't need to be. I think the most important thing to remember is that knowledge is power, especially in a world right now where the United States has one of the highest mortality rates for birthing mothers of any developed nation. That's scary and it should change. So why are women not out in the streets rioting about this? Because mortality rate is acceptable, but a 0.5% chance of uterine rupture is not reasonable to some of these providers. This disconnect needs to change. Women deserve to be safe in their birthing experiences, and ultimately, they deserve to make informed decisions. You have the power. You can do it.